Right, so my name's Simon Goodall, and this is a confirmation of candidature presentation for the group. Probably a little bit more superficial and over the top overview than Jake's just talked us about, but can happily go into any of it in more detail if you want. So the title of my PhD at the moment is Safe, Accurate, Precise Stereotactic Body Radiation in Clinical Practice. So this is a particularly applied PhD, and it's in conjunction with Genesis Care and the University of Western Australia there. So this is all happening in a clinic or a couple of clinics across the state. And again, it's very applied in practice. So and supervisors Martin Ebert, Benjamin, and Dave Waterhouse at Genesis Care. So we've got a cross-collaborative link. So spinal cancer is basically comes in two forms, a rare and more common form. So the more rarer case is primary cancer. So primary spinal cancer is pretty rare. It's about 10 to 15% of central nervous system tumours, which are only 1 to 2% of all tumours themselves. Secondary metastases, however, are a lot more common. So I'm sure most of us know secondary metastases when the tumour cells from a primary cancer get into the bloodstream or the lymphatic system, move around the body and deposit and produce a secondary cancer site. And that's what we generally call metastatic tumour. So secondary metastases in bones and spines are a bit more common. So around 40% of patients that go on to die from cancer will have had a spinal involvement at some point. And it's generally a secondary cancer, generally a secondary metastases. For a bit of reference as we go through the bodies, this is the kind of spinal region. It's divided up into 3 different areas: lumbar, thoracic, and cervical spine. And then we've got the sacral and the coccyx, which are kind of in the same, well, they're generally discussed in the same region, but most of this spinal saber work focuses on the cervical through to lumbar spine. Gets a little bit more complicated in the sacral region, and we can't use quite the same techniques. So the cancer itself is generally located within the bone. So most of the time it's the bony metastases, but occasionally we do get epidural space involvement. So these are some images from this paper from Brett Cox's group, which is about guidance on how to delineate and target spinal cancer. So this top one, you may be able to see this is kind of a vertebral body. This darker region across the back wall is like a tumour volume that we don't want to be there, and this is the spinal cord or the spinal canal in this region. And this sort of sagittal image is the same thing. So you can see this is a good classic example of a metastases which is localised within the bone and it's self-contained in the bone. And on CT you can just about see this one as a kind of white region. This is a similar sort of example where you have got epidural involvement, so the tumour's grown and expanded into the spinal canal and is pressing on the cord, and this can kind of cause a lot more severe symptoms. You can see this again in the sagittal image where the kind of mass is pushing into this cord, which you don't want, and it looks a little bit gnarly on CT as well. So when we look at these, but that's still there. So we've got different shapes of target or different shapes of vertebral body for different areas of the spine. So for the cervical, thoracic, and lumbar again, which makes targeting a little bit different, a little bit more complicated for different areas. But it's divided up into these 6 segments every time, with the vertebral body, the pedicles at 2 and 6, and the lateral process 3 and 5, and the spinous process for number 4. So when we're looking at this imaging, we're creating these bony targets, and then into the epidural space we can talk about these kind of 6 segments, and we treat them segmentally according to these guidelines. So something like this that's got an area or GTV kind of region, tumour region in the vertebral body would treat this whole vertebral body region. So there's typical symptoms that you get from this are pretty wide ranging. So generally you can have patients that are largely asymptomatic, but it ranges fully through to fully debilitating disease. So it's a really variable cancer, and the findings are very patient specific. Most commonly it gets diagnosed through back pain if it's not diagnosed through incidental finding. And side effects or the prognosis falls into two categories, which is myelopathy, which is when the spinal cord itself is actually compressed, so you can have either the discs or the bone pushing onto the actual cord itself and causing some kind of compression, or radiculopathy, which is a pinching of the nerve roots leaving the spinal cord rather than the actual cord itself. And they manifest in the patient through kind of numbness, difficulty walking, all the way up to paralysis. So it's a really variable in symptoms, in the fact that you can have asymptomatic patients all the way through to patients that have full paralysis and can no longer walk. So the need for treatment on these patients varies again. There are three kind of major treatment options for these patients: so surgery, chemotherapy, and radiotherapy, which are the common three that we always hear about. Surgeries can be, or are, extremely invasive and basically involve getting all the way into the body, into the vertebral bodies, and you normally end up with some kind of implants post-surgery that are kind of holding the body together. They basically go in and scoop out the tumour, which can leave quite a lot of instability in that vertebral body. And they have to, of course, be extremely careful not to get anywhere near the spinal cord. So it's kind of high risk, highly invasive procedure. So if we can avoid that, we want to avoid that. Although surgery is the kind of primary treatment option. Chemotherapy, which you know about, is intravenous drug administration with this anti-cancer drug here, which sounds fantastic. So that comes in and targets tumour cells and hopefully leaves the intact and healthy tissue with as little damage as possible. Radiotherapy is the option that I'm looking at during this project. So that's external beam radiotherapy, so use of high energy, high dose radiation therapy to treat these targets. This is a very nice way to go, especially for those patients at the lower, those patients at either end of the spectrum, because it's completely non-invasive and it's an outpatient surgery. So for asymptomatic patients, they can literally walk into the clinic, lie down, have some treatment, go home, and for a large part don't really know about it. And then again, it can be turned around extremely quickly, so you can get a radiotherapy treatment completed within kind of 3-4 hours from start to finish. So if you're a patient that's suddenly got a paralysis from a compression of the cord, then it can be a quick way to relieve pain and relieve symptoms. So it offers some good options. Currently, radiotherapy, or historically radiotherapy, has been more primitive and then a little bit more advanced as we go. So originally we generally would treat this with a kind of APPA technique. So that's an amp post-amp beam, so a beam from the front of the patient and the back of the patient. And you end up with some isodose distribution that looks kind of like this image here. What's the note is that the red isodose line is the kind of treatment isodose line, and you can see it kind of blurs all the way through the patient. So this entire area is getting reasonably high dose of radiation. And then these two isodoses here are over the top of the radiation. So actually the spinal cord, which is shown in this, or the spinal canal, this would be in this yellow mark, is receiving kind of significantly more than the actual treatment dose, just to kind of relieve patient symptoms as quickly as possible. More recently, volumetric and IMRT based treatments have allowed us to get a bit more advanced, and we can pull the high doses off the cord and allow us to treat these volumes with less radiation less high dose radiation to the patient. So they're starting to advance, and we're starting to see better treatment. And in emergency quick cases, again, these can be quite useful techniques. But for those patients where we have a little bit more time, what we want to move towards is stereotactic radiotherapy. So stereotactic radiotherapy has been shown to provide a more sustained relief of pain. So the pain relief can be greater, but it also lasts a lot longer. The problem with conventional radiotherapy is it's delivered quickly and it gives patients relief from pain, but after about 6 months that pain can recur. With stereotactic radiotherapy, the early studies are showing that sort of 12 months to 2 years later, that pain has still subsided. So you're getting slightly longer to get treated with a higher risk treatment, but the pain's actually going away for a long time. And when you're irradiating the spinal cord to such high doses, you can't really retreat too frequently, so the longer you can keep the pain away, the better. So stereotactic radiotherapy itself consists of a kind of four key stages. I guess there's a lot of stages you could break this down into if you wanted to. So I've gone for these kind of 4 overviews. So there's a simulation with multimodality multimodality imaging, some treatment planning, plan quality assurance, and then image-guided treatment delivery. So the difference with stereotactic radiotherapy from conventional radiotherapy is that we use a much higher number of small complex beams or beamlets or beam segments, however we want to phrase it. And those extremely high number of small fields overlap to produce this with some extremely conformal dose distributions which have extremely steep dose gradients. But to manage to achieve this, we need to have a higher level of calibration accuracy, high level of modeling, higher accuracy of dose calculation, and then higher levels of quality assurance and validation. So this is relatively new in terms of treatment of spinal metastases. So a lot of these areas are not fully explored in clinical practice yet. So this is multimodality imaging, which we kind of saw on the previous slide. But we generally need at least a CT image for dose calculation, and we need a couple of MR images. The difference here is that when using these multimodality imaging, we can actually see the spinal cord. So on the CT here, you can see this kind of grey area, which is the spinal canal. And you can kind of see, again, it's a poorly differentiated area, grey area here, which is the spinal canal, which contains the spinal cord, but also contains fluid around that cord. And the fluid can hold a pretty high dose. So using this multimodality imaging allows us to delineate gross targets, clinical targets that we know have involvement, also the cord more precisely. And it buys us just this little bit of space. So I've just measured in here, this is kind of 3 to 4 millimeters. So it's not bought us a huge amount of space, 3 to 4 millimeters, but it allows us to achieve a lot more when we combine it with stereotactic treatment planning. So this is the same patients with a clinical plan. Too much about what these doses are, but the concept being that this isodose line here is the 62% isodose line, and this line here on the back of the treatment volume is the 100% isodose line. So we've got an almost 40% decrease in dose across that 4 millimeters. So you don't need to buy a particularly large amount of space to be able to get a lot more aggressive with these treatments. Whereas before, in the kind of conventional radiotherapy, we're seeing excess dose into the spinal cord. Just by generating that 4 millimeter gap, we can actually get the dose down by 40% and allow these safe treatments. And the other thing to mention is that Monte Carlo treatment planning algorithms are becoming a lot more common practice, which is something else which is not fully understood or well documented in the literature yet, the effects that they have when it comes to actual clinical practice. The way they work is well documented, well known, but actually applying those clinically is still quite a new area. Following these plan creations, we will generally recalculate this on some kind of phantom. This is just an example of a phantom we have within Genesis, which we can use to measure this dose distribution and make sure that the doses we think we're going to give to the patient are what we can actually achieve. Make sure that a machine has that high level of calibration that we think it does, and that we have that high level of accuracy and precision that we think we do. And then the final step is the image-guided treatment. So again, this is something that's becoming more popular now, is to have onboard imaging for your treatment machine. So the ability to generate some kind of cone beam image or some kind of stereoscopic image on treatment set to make sure your patient's in the right place and that dose is going to be delivered exactly where you want the dose to be delivered. Some of these images are probably not too clear for people that have not worked too much in the clinic, but these are quite advanced and quite good images. So the PhD overview for my approach for this, we're going to have kind of 3 aims with subsections underneath it. So the first one is to establish how we can use these Monte Carlo calculation algorithms in clinical practice, taking them from being high-end research algorithms into clinical practice research and have the gold standard of dose calculation for actual patient treatments. The second one is to look a little bit at what level of MLC and in that calibration we actually need to be able to achieve those dose distributions in a way that's going to make sure that our patients have good clinical outcomes. And we're particularly interested in doing that in clinics which have multiple machines across a state, across the centre or across the country, to make sure that patients can be treated on any machine and interchangeably if possible, It's okay to have an extremely highly calibrated, accurately calibrated machine, but if it means your patient's got to wait weeks and weeks to get their treatment, that's not great when they're in severe pain. And then finally, we want to have a look at the effects of spinal fixation hardware in relation to being able to treat these patients. So for those patients that have had surgery first and need a follow-up treatment of radiotherapy, some of these metallic or potentially non-metallic implants can have an effect on the dose distribution. So we want to look at how we can actually go on to treat these patients properly. At the moment, people often avoid these because of the risks around the spinal cord doses. So the first aim 1.1 was to have a look at Monte Carlo calculations, which contain statistical noise. So we're used to seeing quite smooth isodose distributions in treatment planning and radiotherapy, but we can have a range of settings which allow us to calc things a lot quicker and get patients to treatment a lot more quickly, but they give us this noise and noisy isodose distributions. So we wanted to have a look at how these settings affect the ability to make good clinical decisions based on a treatment plan. So I've got a kind of some sort of rough step-by-step methods on these slides, but I won't go into too much detail about how we're actually going to do each single thing, just for the sake of time. The second thing we want to look at is a calculation of dose to medium, which differs from historic calculations of dose to water. So this is another function of Monte Carlo dose calculations. They inherently calculate dose to medium, whereas previous treatment plan systems have historically calculated dose to water. It doesn't make much difference across the body apart from bony regions, which is exactly what we're looking at here, where doses can be sort of 10 to 15% different. So we really want to try and establish if these differences between dose to medium and dose to water are clinically significant when it comes to prescribing patient treatments, and if they are, do we need to change patient treatment prescriptions, because our clinical data is based on the historic outcomes of patients who have had dose distributions calculated with dose to water. So if this is given us the same dose from the TPS, but the actual dose of the patient is going to be 15% different, we need to work out if there's a way that we can update and adapt our prescription processes to make sure the patient still has the same clinical outcome. And then the third aim is to try and work out how to use these new complex treatment planning systems to determine a kind of optimal planning solution. So within the TPS, there's multiple different options that can range from VMAT and IMRT, which could have entire presentations themselves as to what they are. And then we use systems of inverse optimization, which have broad ranges of different parameters, which allow you to kind of ask for whatever you want. So we want to work out what's the most optimal solution in terms of the ability to achieve a good dose distribution that's actually deliverable to a patient and provides good clinical outcomes. The second aim is going to be to assess the precision of MLC and Linac calibration, which allows us to deliver these treatments properly. So as I said, we know this can be done, and there are publications that show that it can be done. What we're interested in is how can we roll this out in a clinical practice where you might have 5-6 machines at a given site, or you may have 10-20 machines across a country, and you want to be able to treat your patient on any machine any time so that you can provide the access to care for patients in the most timely fashion possible. So we want to have a look at how similar does the data need to be for each one of these to allow us to do that and to switch patients around on a daily basis. And then the third one is the evaluation of the spinal fixation hardware. So this is the image from the earlier slide, which maybe makes a bit more sense in this context. But these patients have these implants post-surgery. They can be screws, rods, cages, all sorts of things. So we're going to have a look when this interacts with the radiation. It can produce a lot more scatter, which concerns us about producing more dose to the spinal cord. So we want to work out if these new Monte Carlo algorithms can calculate this accurately and if they can provide us reliable data. And if not, what are some kind of planning techniques that we can introduce to mitigate the risks of severe reactions to the spinal cord by treating these high doses. We wanted to see if we can still maintain these aggressive treatments that provide substantial long-term care, long-term pain relief for patients, especially post-surgery with these things in their back where they don't want to be having repeat surgeries. So we're going to need a phantom to do that. So the first thing will be to produce a phantom that holds some of these surgical implants and some detectors that allow us to make these measurements and assess their accuracy. And then we also want to look at the potential way to generate the treatment plans, as I mentioned. And the other thing of interest is whether the artifacts from these implants have create issues that allow us to not treat the patients as accurately as we like, be that in treatment target delineation or potentially onset treatment imaging. If we're not able to set the patient up and align them accurately, then we can't go as high with these doses as we like. So as it kind of shows you in the slide before, 4 millimeters allows us to get the dose from kind of 50% to 100%, or 40, maybe a 40 or 50% drop off in dose, which is great, but it means if your patient is positioned 2 millimeters wrong, suddenly the dose is 20+% higher, which has pretty severe side effects. So we know the dose needs to be within about 5% of what it should be to get the clinical effects we are after. So 20% overdoses to spinal cord can be pretty serious. So we need to make sure that we can align these patients properly. So progress so far, as I'm a part-time student, just approaching 2 years part-time, 1 year full-time equivalent. So the first one is we've published this first paper and achieved this aim point 1.1, and that was also presented as a poster at EPSM last year. 3.1 is completed, so this phantom has been produced and is ready to make measurements for the 3.2 part of the process. This was published, featured on the front cover of Medical Physics Journal, which was quite nice. And then aim 2 is kind of completed. There's a manuscript under review for that with Journal of Applied Clinical Medical Physics. So assuming that goes on to be published, that bit is complete and we can move on from there. Be under review, so fingers crossed. Which leaves these 3 aims to carry on with. So in the next step, we're going to recommence on some work on 3.2 with these surgical implants. So we'll be doing some scanning in the water tank, and then making measurements in the phantom we produced, and then returning back to finalize the 2 parts of the treatment planning process. Some references from these slides, and yeah, thank you. If there's any questions. I'll leave the chat there too.
No.
It's fine, it's gone 5 o'clock.
Is there any plan for, say this is successful and gets implemented, follow-up research of actual patient pain measurement outcomes from after implementation?
Yeah, so it's definitely something that would be nice to do. So within the clinic, it's easy to do these. Well, there are still technical things that need dealing with, as outlined here. We are treating these patients, so like a lot of the patients we can treat, just not as kind of readily or freely as we like. The problem is always having systematic or good quality data collection on that following up. So we should be able to. I mean, we treat probably 100 of these a year, so hopefully it'll be there. I've not set it up as an aim because, yeah, it relies on clinicians collecting data in a reliable fashion, but potentially it would be nice to see. Particularly be nice to see how some of these technical aspects correlate with clinical outcomes, I think, if we can get that data.
When you say there is 2 millimeters error, is that the error due to the setup error or the machine-specific error, or?
Yeah, I guess that was just a ballpark figure, but I guess the concern around that part of the research is the artifacts in the imaging, and then when you're trying to complete registrations for a patient with a cone beam versus a CT, you've different levels of artifact. So there's some issues around treating the spinal implant patients, which are associated with the dose scatter from those implants, but also the ability to actually position a patient in the right place. So I guess just using 2 millimeters as an example, that if you find that this scatter only allows you to then, or the image artifacts only allow you to position your patient with a 2 millimeter accuracy, you start to worry because your dose has gone from 40% to 60% to 80% quite quickly. I still need to characterize what that is, but that's the kind of thing we'll be looking at is exactly how accurate can you get that and how much of an effect does it make, and potentially are there different imaging systems that allow you to position more accurately. Particularly stereoscopic imaging might allow you to position more accurately for those kind of patients than cone beam, for example.
Just going to ask about the phantom that you designed, if you don't mind going back to that slide.
Sure.
I think maybe I'm just going to ask about the double-hand metals. I'm not sure whether in the publication it was only about the design or about the possibly measurement that we've done, considering the artifacts that we've done there. Whether they correlate, I mean, whether there's how do they agree with the calculation?
Yeah, so that's, I guess, at this point, this publication is just about the phantom production and producing something that's tissue bone equivalent and housing those inserts and detectors, arrays. This is literally design and fabrication publication. The next part will be to actually use it for something like that. So hopefully by the end of the year we'll have those answers. But yeah, right now it's all exciting prospects.
Thank you. I guess that interesting part of the 2 millimeters and the trying to look at the you remove the artifacts to actually account for the accuracy.
Yeah, it'd be interesting to see how accurately you can get those patients. It's a very complex case to treat a patient with titanium implants in the spine like that, I think.
Maybe you can ask Brian to just
That would be nice, yeah.
Any questions from Zoom?
Not yet.
There is no questions from Zoom. Thanks very much, Simon.